So newborn screening is a set of tests that are done to diagnose or at least gives a heads up on certain diseases which we try to pick up even before they present the clinical scenario, which means before they manifest the symptoms, we want to catch the babies with the diseases so that we can prevent further progression of the disease. So when we are doing the test, the baby may be absolutely asymptomatic. So suppose when you're doing another test for somebody, you're doing MRI or CT, it's because the patient has the symptoms. But screening is done in an absolutely well baby to identify whether the baby is at risk for some diseases which can be preventable with treatment. We have to zero down on what are the essential diseases that we have to screen. I think I would be putting it on congenital hypothyroidism and congenital adrenal hyperplasia. And if you see the incidence of congenital adrenal hyperplasia in India, though we don't have a very concrete number, but it's almost around 1 in 5,700 to 6,000 births. And this, if we find out at the right time and a treatment plan is done properly, we can prevent family stress, unnecessary identity crisis, prevention of death in the baby, prevention of cognitive impairment, and also growth failure in these children. So if a panel can include congenital hypothyroidism and congenital adrenal hyperplasia, these are the two screenings which has to be done mandatorily because they make a life-changing difference for the child and the family.
So in healthcare, technology is the big lifeline, to make sure that we are able to diagnose anything early. And screening is the earliest form of diagnosis. And when it comes to newborn, it's even more important that we diagnose at birth. And this is the recommendation from WHO. There are some screening that is mandatory as per the WHO guidelines, and which is basically hearing, screening for hearing, screening for the ROP for the eyes, and jaundice screening. And of course, there is also metabolic screening, which is mandated. So when you ask me how technology plays a significant role, we have point-of-care devices, that are easy to use. It can be used by even trained paramedics. It does not even need a specialist. A trained paramedic, right from the date of birth or day of birth or within 3 days of birth of the baby, can perform these tests. And these are very simple to use point-of-care devices. It gives you results in less than 2 minutes. Let me take the example. Just look at the kind of technology and the costs, today associated with the treatment versus a screening device as this. And when we use the screening device very early, within the stipulated time that is recommended by WHO, the cost of care tremendously comes down. So in my view, early screening with the right technology significantly reduce the cost burden and also support a normal life, a normal and healthy life for the baby. Because when we spoke about hearing screening, hearing is directly related to speech development and brain development. The more we delay the screening and the more we delay diagnosis, if the baby has a problem, it's going to significantly impact the baby's life. And of course, the cost of care is going to be even higher as we delay it further. This is very important to know because typically, babies, when they are born, 80% of babies, can have elevated levels of jaundice, and it's very important to screen that early. And we cannot wait for the baby to show those signs, and then it's already late. And then treatment, and of course the timing of treatment and the impact, is much more severe if we do it later than earlier.
Now, as part of the World Hearing Statement, there's also a specific focus on the newborn screening. So the hearing assessment is not just for newborns. The hearing assessment is for everyone. But to be very specific, we can also go on to the newborn hearing screening. If you look at the newborn hearing screening, one of the strongest body which is giving a lot of recommendations, which the whole world is following, is a JCAH. It's called the Joint Committee on Infant Hearing. Right. So JCAH has given a lot of position statements on it. Now, this JCAH position statement is what is globally accepted and globally is followed. Even if it is WHO adopts the JCAH thing. Now, the thing is, there are certain things that we need to actually, adopt or make some changes with respect to the country and the society or the culture which we do the newborns hearing for it. For example, the protocols that we have in the United States may not be the same that we can have it in India, because we have different other factors that can influence or impact the screening program. So we have to consider those factors into it. But the core, the concept of newborn hearing screening is basically to identify children as young as 1 month and diagnose them as young as 3 months of age and intervene them as young as 6 months of age. So it's a 1-3-6 thumb rule is what is accepted all over the world. Now the question is, what is the status of this newborn hearing screening in India? Is yes, I mean, it's a concept which people are really aware of it at the moment. And there are a lot of newborn hearing screening programs happening in small pockets. It's not a universal screening program. It's not a state-wide screening program or a country-wide screening program we have. As of now, we don't have anything like that. But independent hearing program in islands, maybe 1 or 2 hospitals in these states. Gujarat may have 1 or 2, Maharashtra may have 5, Tamil Nadu may have 10. So sporadically, we are doing newborn hearing screening program, which is not consolidated. There is no consolidated framework on how to execute this newborn hearing screening program. Now, the buck doesn't stop when you do the hearing screening. So actually, when you screen, you can have 2 types of results. You can have babies who can pass the test. You can have the babies those who can fail the test, or we call it as a referral, right? Now, once the child is referred, that means when the child fails the first level of hearing screening, which happens usually within the first month of birth, the child has to do the follow-up screening, right? Now, this is where the problem, the catch is really there. So even in the United States, till 2015, 50% of the children, those who are referred, could not do the follow-up. This is a status in even those developed countries. And this is exactly something which we will have to address in the next level. So first, now we are at the first step of creating an awareness on newborn screening. The government is very much aware that newborn hearing screening is very important. Certain state governments has implemented, especially Tamil Nadu and Kerala has started. And eventually other states will start. Now, once we start screening, then we'll get into the next level of intricacies. How do we do follow-up? How do we monitor them? And all those things will come into play. To put it very precise, yes, everybody is keen to adopt this newborn screening program. Every professional organization body is giving pressure onto the government to start the newborn hearing screening program on that. So the government is very much aware of it, and they've taken the first step. And it will take another 3 years time to consolidate the whole thing, as per my prediction, if everything goes well. So this is the status on newborn screening at this point of time in this country.
Retinopathy of prematurity, or what we call ROP, is the leading cause of blindness in infants across the world. And India it actually affects preterm babies who are born low birth weight. And India has the highest number of preterm births of any country in the world. We have about 3.5 million babies born preterm annually. The incidence of ROP in India varies between 22 to 54%, depending on which study and which area of the country you're looking at. Initially, it was thought to be a disease of the urban areas because you had to be born premature and you had to survive. But over the past 10-15 years, preterm babies are surviving even in the rural areas, in district hospitals, in taluk hospitals, because we have amazingly improved neonatal care. But with this, unfortunately, ROP screening or the screening services for this disease hasn't caught up. So that's really where the problem is. 3.5 million babies born preterm and about 200 or less than 200 doctors to take care of it. ROP screening has to be done when the baby is less than 30 days of life. So before the baby turns 30 days old, the first screening has to be done. And of course, if it needs an ROP specialist, and there are such few, then you have to bridge the gap with technology. So what we've been trying to do here in Karnataka through the Karnataka Internet Assisted Diagnosis for ROP program, or the KidDrop program, since 2007, is we have trained technicians and nurses and paramedics to take pictures of the retina of these preterm babies who are born in the rural centers. and through a telemedicine platform, these are read by the ROP specialists, and then treatment is delivered where it's required. That technology was expensive, and one of the things that we've been able to do is bring down the cost of that technology, and by making Make in India product a few years ago, and well, that's the way the technology is bridging the gap now.
Dr. Prashant Gowda, can you shed some light on the basic metabolic screening tests that should be done?
First of all, thank you for the opportunity, and it's indeed a need of the hour, the metabolic screening. So basically, we will be, what is metabolism? We have what we consume, carbohydrates, protein, fat, which enters when it enters into the system. This is how it breaks down, and each of the carbohydrates, proteins, or the fat metabolism is done by certain enzymes. So if there are thousands to lakhs of different type of enzymes, coenzymes, which help in the metabolism of the food what we ingest, if you have to talk in a very common language. If any of the process where whether it could be carbohydrate metabolism, protein or amino acids, or any of the associated metabolisms, if any of the enzymes are missing, that can lead to a problem or accumulation of certain type of metabolite, which can damage the liver or kidney, or get accumulated in the heart or in the brain, or different systems, different organs of the body, and that can cause problem. So it is very important to identify what is the metabolism problem in the baby right from the birth, and that's the reason why the concept of metabolic screening has evolved, through which we try to find out whether in any of the if any metabolic disorder exists, we don't have a permanent cure for it. But if we try to eliminate certain type of food items, which ultimately ends up with certain type of metabolite for which the body is not does not have a certain component of that particular metabolism to complete, that will help in having a good survival with good quality of life for the kids who are born with metabolic disorder. So that's why this importance has been identified not only by the private sector, even in the public sector, and even with government as well. Now they have started doing metabolic screening. If there is any problem in a thyroid metabolism, if it is recognized early, it can give a good benefit for the baby's growth and development.
So for the newborn screening to be successful and to be done for every single child, a proper counseling has to be done to the family. So even if the family is getting discharged within 24 hours, when they understand that we are planning a screening for the baby to prevent a cognitive or a mental retardation or further uncertain hospital admissions, they are always willing to comply with the screening test. Only if we don't signify the importance to them, it can go missed. So as a protocol, if the hospital or the delivery protocol says a newborn screening has to be done, it will be done at 48 hours. Should the baby be discharged before that, the baby will have a second review within 5 days, wherein the screening is definitely done, and it is also counseled to the parents. But the gist of it is, it has to be somehow done between 2 to 7 days of life.
One of the first things that we did when we started Genworks, we wanted to move away from just a transaction, and we wanted to be providing solutions to our customers. And when we say solutions, and we are talking about affordable care, it's all about early screening, early health, and also being responsible about not just selling the high-cost diagnostic and treatment devices, but also bring in or add a screening portfolio. And that's why we when we partnered with best-in-class companies who are across the world for screening solutions as well. So in this case, for newborn screening, we tied up with Natus, which is the gold standard in hearing screening. And then we tied up with Menon for jaundice screening. And of course, we have an Indian company which does ROP screening, which is also a very essential, screening to be done. That's the first thing. First thing, making those important tie-ups, bringing it to India and making it affordable. The most important thing is to bring in awareness to the doctors to tell them that we have this. Doctors know that these are important, but they did not obviously know where to get it and who to get it from. And they were too glad that we brought this to them. And, almost immediately, they could adopt. And then the second thing which we did was we conducted a lot of seminars, awareness programs. We continuously work very closely with NNF and then specifically with NNF Karnataka, who do pioneering work in taking awareness of all these technologies across the doctors, both in Karnataka and across the country. Right. So, and we very regularly participate in National Neonatology Foundation programs and state level programs, and we get our users, the doctors who are already using this technology and who have made significant impact to come and talk about these products. First level is obviously, I believe, is to bring in awareness to the healthcare, to the doctors, to the healthcare fraternity, and to tell them that, number one, it's available, number two, it's affordable, and number three, it's easy to use. And we can, even a paramedic could use it. And we have done a lot of these awareness programs, and this made a very big impact. The second thing is, once we sell this box or this product to a center, we also make sure that we create marketing templates, posters, videos that can be circulated to their stakeholders. So today, if there is an hospital or a nursing home who has bought this device or who have these services, we help them to promote it to the local community, just to bring out the clinical value. We don't get into the commercial aspect at all. We just give them the clinical evidence as how this can impact, and the impact for early health and affordable care. That is a second thing that we do to build awareness. And the third thing, obviously, is to make sure that there are every month, in the calendar year, there is a focus on one specific area where there needs to be a focus. So there's a hearing day, there is an ROP day, there is a preemie day, and a preemie month or a preemie day, which is already part of the healthcare calendar. And we use that opportunity to, in our social media handles, promote the awareness for such, and also about the partnerships that we have. These are three things that we constantly do to build awareness, and which has really reached, the length and breadth of the country, thanks to our distribution being available across the country, and the relationships that we have with customers in these geographies across the country, not just the metro and tier one, but panning across India. And to your point of how we can make it, accessible, where we have also built a platform, a digital platform, where we can also provide interpretation services. So now there are two things which we can support thanks to technology. One is for some of these solutions, there is an AI layer which can support with interpretation, even when there is no expert available. So especially the ROP. We have an expert, who provides the services and who can, support a paramedic perform this. So as a trained nurse or a paramedic to perform the test, and they could, give their interpretation. We have tied up similarly for the hearing screening with MUF Foundation, who can provide the interpretation and guidance or support, for remotely, not just at point of care. At point of care, a nurse or a paramedic would do the test, and remotely a specialist would guide on the next level of care, which obviously is a diagnosis, next level of diagnosis or treatment. And we have also built hub and spoke models. When I say hub and spoke models, how we can connect level 4 newborn care or NICU, where the babies in the maternity homes can be connected remotely through a hub and spoke model, where these services can be done at the maternity home, and the specialist or the neonatologist at the level 4 care can support in interpretation and services. Through this, we have leveraged technology to make it accessible and obviously affordable as well, because the patient is just going to pay for the test, and it's typically 300 or 400 rupees, which is not a big amount of money compared to the level of cost that we can save on treatment, and also on the impact on the newborn.
Done so far?
Just last month, we crossed about 200,000 baby imaging sessions in about 75,000 babies. And more than 3,100 babies have been treated for ROP, and blindness has been prevented in them in the rural and in the semi-urban areas. When you look at the fiscal equivalent, there is a formula called the blind person years. And we reckon that more than $100 million worth blindness can be prevented if these babies are screened and treated on time. So that's really the impact, because as you can imagine, preventing a baby from going blind when he's 1 or 2 or 3 months old is preventing this baby from being blind for a lifetime. And this child then grows up and contributes socially, economically to the country. So
in hypothyroidism, if it is not detected, because of maternal hormones which baby would have acquired before birth, it will serve for few days or few weeks. Once that thyroid hormone concentration in the body reduces, it is important for baby to produce their own thyroid stimulating hormone and own thyroid hormone through the thyroid gland. If that is not happening, over a period of time, you'll observe few weeks, baby will start having hypothyroidism features like excessive weight gain, brain maturation does not happen. A baby which is born or destined to achieve great heights, if it was detected early and treated early by externally providing thyroid hormones in the form of tablet, if that is missed, they can become mentally challenged because of lack of brain growth. So it is very important that in order to identify it and initiate the treatment at the earliest. So it is very crucial. A baby born to achieve certain things, to become Einstein or an actor or whatever, or sports person, or to lead a normal life, since we didn't detect that particular congenital hypothyroidism, which could have been rectified by simply providing the thyroid supplement orally, that baby not detected, say after 1 month, 2 months or 3 months, their brain will not grow and they become mentally challenged for life. And even if you treat later, say after 3 months or 6 months, they cannot have a normal life, because brain is an end organ. Once it is damaged for life. So it is very, very crucial to do metabolic screening and not to miss thyroid, and to initiate the thyroid replacement at the earliest.
If you do not detect the child at a very early stage, right, there can be many problems. Now, let's start with 2 groups of babies. Okay, there's one group of baby who has no risk factors, born absolutely normal. There's no other risk factor. There's no prenatal factor, no perinatal factor or postnatal factor. Now, these children every child is endorsed to screen. So they need to be screened. And if they pass the screening, then that's it. So that means we confirm the child has normal hearing and there's no issue with the child's hearing and also with the development of hearing skills. We also have other group of children, those who are born with risk factors, right? Or we call it as NICU kids, right? Now, this NICU kids is something which is very, very important, right? Now, even if they pass the screening in the first phase, they have to be monitored for the first 3 years of life, because a hearing loss can manifest any point of time in the early childhood for them when they are at high risk, right? So this is something which everybody has to keep in mind, that newborn hearing screening, that we do it on the first phase, maybe in the first month or the second month or third month, is not the perpetual report throughout the life, right? So whatever is the degree and type of hearing loss, you can still restore hearing for them. So which means there is a solution to restore hearing, right? But the problem is to identify that. So most of the kids are missed out simply because there is no early identification. If you have a screening program, very good screening program, you identify kids with the hearing loss. And if you don't have the management options, if you don't have the intervention options, there's no point in doing a screening. Treatments are available and it's very much accessible and it's very much affordable. But the biggest challenge is to identify these kids and intervene them as young as possible, right? Now, the problem would be, if you don't identify them at early and if you don't intervene them. This is very similar to the your earlier question. So the problem is they will not have normal education. They will not have, they can't be independent. They're dependent. And especially girls, when they give to the, I mean, the parents only realize when the girl reaches the age where they have to get them married, you know. That's when they realize, you know, the child has got a great impairment. Till then, it is absolutely neglected in the society.
So a clinical examination is the first part of a screening which has to be documented from head to toe to make sure that the baby is phenotypical, but that is by look, he does not have any risk factors.
If you don't detect early and if it is left that way, baby is born to achieve complete potential in terms of growth, development, and lead a normal life. Because of lack of thyroid replacement for a thyroid deficient or congenital hypothyroid baby, they can have an immature brain growth and they can become mentally challenged for life.
Screening plays a crucial role in saving and improving babies' lives. Emerging economies have shown success in addressing child health issues such as infections, malnutrition, and diarrhea. However, to further improve infant and child mortality rates, newborn screening should be adopted. Of the 134 million babies born in the world every year, only about 1/3 receive screening of any type, and many babies are only screened for 1 or 2 conditions. Broad disparity exists around the globe regarding access to newborn screening. Resource limitations have affected countries' ability to implement robust screening programs. So newborn screening is the best possible preventive healthcare. It is easy and effective. Early detection of congenital hypothyroidism is a life-changing experience for the affected babies. Based on several published papers, cost-benefit ratio of hypothyroidism screening is on average 4 times. Considering the high incidence of congenital hypothyroidism, generally 1 in 1,300 live births, screening has a huge impact in improving the health and welfare of society. For the government, it's better saving money by screening and treating condition rather than incurring the lifetime cost of care for an individual with an intellectual disability. India continues to make a significant improvement around the newborn screening disorders. Many states within India are implementing pilot programs for newborn screening through the generous support of the state governments and other organizations. In Delhi alone, nearly 900 births take place every day. Considering this figure, there would be 1 or 2 babies born in Delhi alone with a metabolic defect every day. India Council of Medical Research, ICMR, has funded several multi-center studies over the past decades. And according to ICMR task force, it would be beneficial to consider screening universally for congenital hypothyroidism and congenital adrenal hyperplasia, as they both contribute significantly to the morbidity and mortality of children. Also, G6PD deficiency should be considered due to the high incidence and ease of treatment. We have learned today that newborn babies can be screened up for up to 70 potential life-threatening diseases. And the menu of available tests varies a lot depending on the country. Many countries like India have been forced to make a difficult choices as to which newborn health conditions to prioritize. Recently, Ministry of Health and Family Welfare has approved National Rare Disease Policy 2021. The Rare Disease Policy aims to screen and detect rare diseases at early stages. Considering the competing priorities within available resources, universal screening of all babies in the country for all rare disorders is not feasible. Thus, the Indian Rare Disease Policy recommends a screening for all women who has a family history of rare diseases. PreClinical is committed to working with the Government of India in addressing these priorities.
Now, there are certain guidelines for the examination in the first trimester scan, which is performed when the crown rump length is between 45 to 84 millimeters, which corresponds to 11 weeks to 13 weeks and 6 days. So we confirm that the baby is alive, or there are more than one babies. We confirm the chorionicity of the pregnancy. We measure the crown to the rump length, that's the length, longest length in the baby, and that helps us to confirm the stage of the pregnancy, or the gestational age as we call it. We screen for possibility of chromosomal abnormalities. It is very, very important for early detection of anomalies, and particularly the lethal anomalies, and of course screening for high blood pressure problems and growth restriction, which is far more commoner than chromosomal abnormalities. And that is really the way forward, to combine all this information in one scan so that we can predict the problem. Coming to the diagnosis of chromosomal abnormalities, the only way to diagnose or have a definite, accurate diagnosis that the baby has got a chromosomal abnormality or not is by acquiring the fetal cells, which typically we get from the amniotic fluid or from the chorionic villi, that is the placental tissue. That is called a CVS. Now, CVS typically we perform before 16 weeks, and after 16 weeks amniocentesis is performed. And when we perform these invasive tests, that means we are putting a needle into the pregnancy sac, we must be very careful about how well we do it. We must be knowledgeable about the diagnostic accuracy of the test. Timing is extremely important because we don't want to cause more damage, and technique is extremely important because risk of invasive tests, which is associated with these procedures, is inversely proportional to the operator's skill. That means the more experience the operator has, the lesser is the risk of miscarriage, and vice versa. Now, if we perform invasive tests for everybody, we will end up with a lot more unnecessary miscarriages. And therefore, screening tests become very, very important. Screening for chromosomal abnormalities is what is very important, particularly in our country, because there are more than 500,000 children born every year with congenital malformations. And there is thalassemia major, the sickle cell disease, which are the commonest genetic abnormalities, and over 20,000 babies with Down syndrome are born every year. And of course, now as the average maternal age to get pregnant is increasing, the probability of chromosomal abnormalities in the population is also increasing. And this is particularly in our country very important to diagnose these chromosomal problems in utero, is because the infrastructure to look after these challenged babies in our country is also still lagging behind, particularly in a rural setup or a less urban setup. Obviously, we have to have a high detection rate, low false positive and low false negative for any test to be good. So it's all about a balancing game where we want to keep the detection rate up so that we can detect as many babies with Down syndrome as possible or aneuploidies as possible, and keep the invasive testing as low as possible so that we can reduce the number of miscarriage of normal babies, which is not completely avoidable by any invasive testing. Standardizing the NT scan so important, right? Now, to measure that small millimeter space is extremely important because of this. Because when you have an NT which is increased, the probability of having a chromosomal problem, fetal death, or major defects is increased, particularly the jump from 2 millimeter to 4 millimeter is actually quite significant, right? You're talking about 3% of chromosomal abnormalities versus 20% of chromosomal abnormalities. Therefore, it's very, very important to take precise measurement of the nuchal translucency. Conclusion of that study was we should have an algorithmic based approach to screening for preeclampsia and FGR so that this can be followed with appropriate intervention, which will, of course, ensure better uptake of medications by the pregnant mother, because when you tell them that you have to take the medication for this and this particular purpose, they're more likely to be more compliant to it, and this will certainly reduce the incidence of preeclampsia and growth restriction as well. Finally, coming to the Oscar clinic. Now, Oscar is basically one-stop clinic for assessment of risk. And now when we know that we have got so many problems that can be predicted, and some of them can be even diagnosed in the first trimester itself, the concept of an Oscar clinic becomes extremely, extremely important. So the concept of the one-stop clinic for risk assessment, or the Oscar clinic, is that when the woman comes into the waiting room and is waiting for her to be taken up for the scan, she can give her blood. And when the scan is being performed, which can sometimes take a bit longer, the bloods are run in the laboratory. And by the time she finishes the scan, the blood test results are ready. And then we can give them a complete combined test result. So this is the concept of the Oscar clinic, which is very, very huge in the Western society. Particularly in the private clinics, where a lot can be achieved in a day and avoids these multiple visits as well. So the purpose of the first trimester scan is to confirm the gestational age and viable pregnancy, look at multiple pregnancies, look at the chorionicity, and understand its implications. We must screen for chromosomal abnormalities, which would include, apart from your scan, beta-hCG-PAPA and PLGF. We screen and detect many structural abnormalities. We screen for high blood pressure and growth restriction, and in women who are at a higher risk of more than 1%, we prescribe aspirin 150 milligrams till 36 weeks. It's extremely important to be trained and update oneself constantly, and looking for newer and newer markers and improvising on the scan and the blood test, which is what has brought us from what we were in 2004 when we were doing only the scan to today when we are doing so many things in the first trimester itself. And doing invasive procedures in the first trimester for diagnostic and therapeutic purposes is reasonably safe in good hands. Of course, requires training, but it has been, it's much more widespread today than it was ever before, right? Now the idea of inversion of the antenatal pyramid of care was brought in by Professor Nicolaides, where previously the old protocol, as we call it, which was decided many years ago, when the woman came for far fewer visits in the first half of pregnancy, and as they ended up towards the end of the pregnancy, had many, many frequent visits. But by this time, the problems have already occurred, and we are talking about treatment, sometimes too late. The inversion of the pyramid of care involves doing a specialist clinic, or I would call it the specialist fetal clinic at 12 weeks, where the woman is assessed for all possible pregnancy complications by doing a scan, blood test, putting everything together, right, at the 12-week scan. And now at the 22 weeks, you do a risk reassessment, so that, you know, the ones that you might have missed out at 12 weeks, you would pick up at 22 weeks, and finally at 36 weeks. So in this way, we can triage women in a way that only the high risk spend more time in the clinic and in the hospitals than the low risk, which can be managed much better in community and primary care centers. So in this way, we shift all our screening and diagnosis of major problems to the first trimester and first half of the pregnancy.
Hello. Screening for preeclampsia is an effort towards preventing the preventable mortality. Hypertensive disorders, as we understand, are frequently encountered complications of pregnancy, the major cause of perinatal morbidity and mortality, and this can further lead to more complications also in the future health of the woman. And these are important because we have to understand that preeclampsia is a disorder which is known to complicate 2 to 5% of pregnancies and is associated with convulsions, seizures, cerebrovascular accidents, pulmonary edema, renal failure, liver failure, and DIC in the mother, giving rise to ongoing risks to her health in the form of hypertension, ischemic heart disease, and cerebrovascular accidents. And in the babies, 15% of the times there can be a risk of preterm birth, growth restriction, and these babies born to preeclamptic mothers have developmental delays, obesity, NCDs in the form of hypertension, cardiovascular disease, and metabolic syndrome. So it's a transgenerational affliction, which we have to realize, and therefore all efforts have to be made to prevent this disorder. Now, this particular illustrative slide tells us about the devastating effects that this disease can have on the mother right now, the cardiovascular issues, which can have long-standing effects to her. While now she's been affected by multi-systemic disorders during this particular index pregnancy, which has got complicated, affecting all her systems, she is at risk of having problems in the future, and not only she, her baby. And there are various causes. If you look at the maternal death causes, the mortality, you will find hypertensive disorders are known to contribute nearly about 15% of maternal deaths directly, and so many more indirectly. Placental dysfunction being at the center of the entire thing, and the disease usually prevailing in the first and the second trimester, becoming overt or diagnosable in the stage 2, that is during this end of the second trimester or the third trimester, when the maternal syndrome is well seen. Now, the challenges are women who have suffered from hypertensive disorders of pregnancy, such as gestational hypertension, preeclampsia, SGA babies, or preterm deliveries. These women usually have a pre-pregnancy issue in the form of obesity, diabetes, hypertension, and so on. And these things can be carried to those babies who are born, giving rise to issues much in future. So a lot of efforts are therefore being made of identifying these priori or pre-existing risks, trying to identify the biomarkers instability during the pregnancy, and then trying to find out how it is going to affect the adverse outcomes in pregnancy. So dysregulation of angiogenic factors is associated with maternal oxidative stress, and increased oxidative stress may reduce cord DHA levels and increase in sFlt1 levels, leading to poor birth outcomes. And preeclampsia was concluded by this study that these biomarkers can definitely be used as some way of screening or diagnosing of this disease, which contributes to so much of mortality and morbidity. So identifying these pro-angiogenic mechanisms and the anti-angiogenic mechanisms can bring about ways in which we can early prediction, late prediction, differential diagnosis. So the important questions which are need to be answered are: how well do plasma, serum sFlt and PLGF differentiate between disease? How well do these biomarkers predict prognosis in patients with suspected preeclampsia? Do alterations in these biomarkers serve as early predictive markers, and can we use them as intermediate outcome to measure response to specific treatment? Several groups have demonstrated that measurement for sFlt1 and PLGF can be used to differentiate preeclampsia from other diseases which mimic preeclampsia, such as chronic hypertension, gestational hypertension, kidney disease. So what naturally the question comes is an ideal approach. Ideally, we should be taking the maternal history correctly. We should be looking at the mean arterial blood pressure or the blood pressure correctly. Look at the PLGF, and the uterine artery pulsatility index is one of the propositions. If you look at the NICE guidelines of 2019, it mentions various maternal factors such as hypertension, chronic renal disease, autoimmune diseases, etc. as high risk factors, and certain moderate risk factors in the mother. And additionally, incidentally, the ACOG in 2020 also added on pregnancies resulting out of artificial reproductive techniques also to be at risk of developing preeclampsia. We in India, the Justosis group, devised a better maternal risk strategy, which included risk factors which were awarded quantifying different scores depending on their severity, and especially women who were less than 19 years of age were included because that's a commonality in our country. Maternal anemia, body mass index more than 30, primi gravida, short duration of sperm exposure, SGM mothers themselves, women having diseases, hypothyroidism, PCOS, delivered pregnant due to IVF or 𝐒𝐂𝐑𝐄𝐄𝐍𝐈𝐍𝐆, mean arterial pressure of more than 85 milligrams per mercury, chronic vascular disease and excessive weight gain in pregnancy were awarded 1 score, while women with gestational diabetes, obesity, more than 40, BMI, multifetal pregnancy, hypertension were awarded score 2, and pre-gestational diabetes, chronic hypertension, mental disorders, maternal chronic disease, etc. were awarded 3, and especially ART pregnancies with oocyte donation or surrogacy were awarded as 3. So this was found to be feasible in the Indian setup based on history, and mean arterial pressure was found to be cost effective, and women who have a score of 3 or more were depicted as women at risk and then were analyzed further much in detail. Now, HDPs are the major causes of maternal morbidity and mortality, giving rise to 19% of maternal deaths due to hypertension in pregnancy. And the National Preeclampsia Registry, 𝐒𝐂𝐑𝐄𝐄𝐍𝐈𝐍𝐆 statistics have revealed that the incidence of hypertensive diseases during pregnancy to be high, with substantial incidence of preeclampsia. HTB continues to be an enigma. We do not know the cause. We only know the consequences. What we know, however, is very little. Spiral arterial remodeling. We know the gun is loaded, but we do not know